I just wanted to quickly draw your attention to where the three presentations focused and where we are going towards in the panel discussions and the presentations from the keynote panelists. We started with the actual people who get displaced or who are moving in terms of their refugee status from one location to the other, the impact on their lives, livelihoods, and food security and nutrition status, to the pressures on the host community and how solutions need to look at both host communities and the displaced populations, to the impact on environment. And Maria, your slide showed the transition in the area where we have the big mega camp in Cox's Bazar. So we are already starting to see just not the impact on people who are impacted due to displacement and other conflict situations, but how it's impacting other people, and in terms of the solutions that basic services need to be looking at. But one of the things that we need to probably a little bit more pay attention to is what's happening to the governance and the organizations within the government structures that are going to be looking at solutions together with other partners. So without much ado, may I request our panelists to come and take their seats on the podium here. We have Tarat Shahid, Challenge Leader, Food Systems Portfolio at Global Challenges Research Fund, UK. At Spikers, former FAO representative and FAO Senior Advisor to the DG FAO. Mesfin Teklu Tessema, Senior Director of Health, International Rescue Committee. Sarah Walker, Senior Lecturer, University of New South Wales, Australia. Each one of them will be doing a very short keynote address, and then we'll be directing the panelists to questions. Thank you.
Good morning or afternoon. I don't know what's out. Yeah, it's great to be here. Thanks very much for having me. We have heard, in the previous three presentations, in terms of the challenge and the issue with nutrition as well as food security in humanitarian context. And the evidence is clear that the effect of conflict on nutrition is negative. I think Daniel has clearly pointed out that. And we know that crisis is also protracted, and average refugee camp lasts more than 10 years. And yet our response is continue to be humanitarian, short-term, 6 months funding program lasts only a few months. So we have issues, and most of the situations that we see in this situation is that given the protracted nature, one example in Somalia, for example, that the level of acute malnutrition throughout the year is between 10 to 12% GAM rate. Yet what we see is actually spikes of crisis level acute malnutrition above 15%. So really we are talking about a population who is chronically suffering from acute malnutrition. So when such a spike happens, our response is typical, which is to set up treatment program for children who are acutely malnourished. And yet, we are not able to reach, the number of people who are year to year affected by this kind of situation. So as an international community, I think we have made so much progress in terms of improving access to treatment for acute malnutrition, especially taking treatment out of facilities or hospital to the community. I think the invention of reduced therapeutic food has enabled us to treat children on outpatient basis. But still, mothers and children are expected to come to health facilities every week to collect their ration and to be monitored until further recovery. But I think the challenge we see that in places like South Sudan and in conflict-afflicted settings, the journey itself is challenging and also risky, and many children don't start or complete the treatment. And the other challenge is that we know that wasting is it's a continuum condition, and the division between severe and moderate is basically based on arbitrary kind of cutoff based on statistical, where you stand from the median, basically, not necessarily based on clinical criteria. So current recommendation of treating children in different types of program with different product, different entities has really not served the people, and as a result, many children don't get the full benefit of treatment. And globally, as we know, only 25% of children who are severely acutely malnourished are getting the treatment they need. So we, as a humanitarian organization, we have been asking ourselves, how can you do better to make sure that we reach those children who need the treatment? And one of the work that we have done is that IRC, International Rescue Committee, with our partners, really testing and developing alternative model of treatment using single product, single protocol, all children treated at the community level using a diagnostic which can be used by mothers, like with upper arm circumference measurement, and instead of weight for height, using community health workers to deliver care at the community level, and simplifying the dosage mechanism, which has actually enabled us to reach more children with the same resource we are currently spending. So we have done randomized control trial comparing the effectiveness of a simplified one program model compared to the standard treatment where severe malnutrition treated in OTP and moderate through supplementary feeding using a parallel kind of logistic and supply chain and different agencies managing. And basically, it's very inefficient. The outcome of the two are quite the same in terms of treatment outcome, but we can treat actually the same number of children with a much reduced, lesser cost to full recovery. So we think this is a way to really improve access. At the same time, this is what we are talking about accelerator here in terms of reaching and making progress. I think it's not acceptable to continue to see 20% coverage for too long, more than a decade. And evidence also suggests that episodes of wasting negatively affect linear growth. So early treatment is also prevention from chronic stunting. So for us is to build resilience and to save lives. We must take forward new approaches and innovations in terms of service delivery. And really, our thinking must keep pace with the threat from malnutrition and hunger that remain or continue to increase, rather, especially in fragile and conflict-affected settings. So I'm happy to discuss further, but I think we have promising practice that we can adapt, and it's the will that to take these things forward. Thank you.